Hello, I'm Dr. AMRITAKSHA DEB. I'll be talking about hypercalcemia and hypocalcemia in this short presentation today. We'll look at firstly calcium metabolism and how normocalcemia is maintained in the body. We'll then look at three clinical cases, and then we'll subsequently discuss hypo and hypercalcemia in terms of treatment and clinical manifestations. Calcium comes from the Latin word calx, which basically means lime. It is nature's most renowned structural element, and it is also the structural element of the human body. So our bones is primarily made of calcium. It is the fifth most common material by mass in the human body after oxygen, hydrogen, carbon, and nitrogen. It is also the fifth most common element by mass in the Earth's crust. Down here we see a lime mine and our Taj Mahal, which is made of limestone. The role of calcium is basically that of ionized calcium. It works in terms of clotting of blood. It works for blood vessel as well as muscle contraction, enzyme and hormone secretion, for CNS functioning, oocyte activation. However, hypo and hypercalcemia are not indicative of total body reserves of calcium. The recommended dietary allowance for women between 18 and 50 years of age and for men from 18 to 70 years of age is 1 gram of calcium per day, though the requirement is of around 700 milligrams. For 50 plus women and 70 plus men, the RDA is 1200 milligrams per day. We can safely give up to 1.5 grams of calcium without causing any harm. The chief sources of calcium is milk, cheese, and other dairy products. Some green leafy vegetables, like okra for example, also contain significant amount of calcium. Soya drinks, bread with added calcium, as well as fish like sardines where bones are eaten can be a source of calcium. Now, in order to understand calcium, we have to also understand the role of vitamin D and that of parathormone. So we'll just look briefly at vitamin D, which is a hormone as well as a vitamin. It is made in an inactive form in skin from sunlight. It is subsequently hydroxylated. The 25 hydroxylation occurs in the liver and further hydroxylated to active form 125 dihydroxyvitamin D in the kidneys. This stimulates intestinal calcium and phosphorus absorption. Without vitamin D, the calcium absorption is just 10%, which rises to 30 to 40% in presence of vitamin D. For phosphorus, the absorption rises from 60% to 80%. It has wide biological actions and regulates more than 200 genes. And so we find vitamin D being used for various different purposes. It is found to inhibit angiogenesis, decrease renin production, cellular proliferation. It stimulates insulin production and macrophage function on the other hand. Vitamin D, this is the flow chart, which basically shows vitamin D being produced in the active form from 7-dihydroxy cholesterol. From there, pre-vitamin D3 is made by ultraviolet exposure from sunlight. This is converted to D3 and then subsequently to 25 hydroxy D3, which occurs in the liver. This is subsequently converted to activated form 125 dihydroxy vitamin D by the kidneys. This binds to vitamin D receptors and the various biological actions of vitamin D occurs. The other important player in maintenance of calcium is parathormone. This basically is a very small hormone, with a very small gland, which was found related to the thyroid gland. This is just as small as a hemp seed, that is the seed of bhang. And this small seed like gland is present related to the posterior aspect of the thyroid gland. And there are 4 parathyroid hormones which are seen, which is of different structure and vascularity compared with the rest of the thyroid gland. Parathyroid works basically by increasing calcium absorption from the intestine by parathyroid activation of vitamin D. It causes reabsorption of calcium in the kidneys, as well as it causes calcium to be released from the main reservoir of calcium in the body, that is the bone. And all this leads to increased calcium production. Increased calcium in the blood basically subsequently works as a negative feedback and decreases parathormone levels. Now, calcium is predominantly present in the bony structures. More than 99% is bound to the bony structures. Free calcium is the one which is necessary for all its other biological actions. Free calcium is primarily a intracellular ion, and there is a very steep gradient of calcium between ICF and ECF, almost like potassium. ECF calcium again is protein bound. Around half of it is protein bound, whereas around half of it is in the ionized form. It's basically less than half is in the ionized form, which is what results in the biological actions of calcium. This is again regulated in a very narrow range by parathormone and calcitriol. If we look at the distribution of calcium in the body, we again see that extracellular is like between 9 and 10 milligram per deciliter, of which 45% is protein bound. The rest is diffusible, of which 10% is complex, whereas 45% is present in free ionized form. In order to maintain calcium homeostasis in the human body, basically there is absorption of calcium from the intestine, which exchanges with the extracellular compartment. When there is calcium deficiency, there can be exchange from the bony compartment as well as from the non-bone compartment, and finally it is excreted in the kidneys. So we maintain a net neutral calcium balance in the body. The two basic defense, there are two mechanisms for maintaining calcium. Basically, we have a defense mechanism for protection against hypercalcemia as well as for protection against hypocalcemia. Both of them work through parathormone. For hypercalcemia, whenever there is increase in calcium level, there is decrease in parathormone and increased calcitonin release, and this will result in decreased mobilization of calcium from the skeleton and soft tissues and normocalcemia. On the other hand, decreased parathormone decreases vitamin D activation, and this will again result in decreased calcium absorption. The reverse occurs when there is hypocalcemia, with parathormone rising as well as vitamin D being produced in more active form, more of active absorption, and more of mobilization from the bones, and resulting in normocalcemia. So we see that hypo and hypercalcemia will occur only when there is serious disruption of hemostasis. This, however, does not reflect calcium balance on its own. Now let's look at the first case. This is a 65-year-old lady who is a known case of osteoarthritis of both knees. She presented to the emergency with decrease in urine output for 3 days, decreased appetite for 3 days, and altered sensorium for 1 day. On examination, we found an elderly obese lady with evidence of osteoarthritis. Blood pressures were borderline low, pulse rate was slightly high, respiratory rate was good, however, hydration status was not good. Systemic examination showed that she was altered, not very deeply comatose, a GCS of 12. Planters were bilateral flexors with no focal neurological deficits. Investigations were significant for mild leukocytosis. There was increase in urea and creatinine, with urea being a bit disproportionately elevated compared with the creatinine level. Sodium and potassium were almost normal. Urine showed trace albumin, no RBCs or pus cells. We found that she had increased ionized calcium of 1.9 milliequivalent per liter, normal being up to 1.1 milliequivalents, and total calcium of 14.8 milligram per deciliter. Serum albumin was slightly low, so if we correct for serum albumin, her total calcium was even higher, around 15.5. Globulin level was 3.3. LFTs were normal. Now, if we look at hypercalcemia, so hypercalcemia primarily can be caused by one, increased absorption from the intestine, two, by increased bony resorption, or three, by decreased like increased renal reabsorption, resulting in decrease of calcium being excreted in the urine. The causes of hypercalcemia are basically primarily neoplastic disease. Among neoplastic disease, we have solid tumors, which can result in metastasis and hypercalcemia. We can have hematopoietic tumors like myeloma, lymphoma, and leukemia, which can result in hypercalcemia. Primary hyperparathyroidism is another cause, which can again be due to adenoma, hyperplasia, or part of multiple endocrine neoplasia, or a primary adenocarcinoma of the parathyroid glands. Vitamin D intoxication and vitaminosis, hypervitaminosis A, can result in hypercalcemia. On the other hand, we can have immobilization, which results in bony mobilization of calcium, as well as certain medications which decrease urinary calcium excretion, like thiazides, as well as very high amounts of calcium being taken, like in the milk alkali syndrome, or in recovery phase of acute renal failure, we can find calcium levels being high. False hypercalcemia can occur due to hemoconcentration. Then we have the granulomatous disease, which results basically in activation of vitamin D. Increase in the vitamin D levels would be like hypervitaminosis, and they too, like sarcoidosis, tuberculosis, berylosis, and other granulomatous disease, can occasionally present with hypercalcemia. Among the endocrinopathies, we find hyperthyroidism and acromegaly, as well as pheochromocytoma, being important causes of hypercalcemia. However, the most common causes of hypercalcemia are neoplastic disease and primary hyperparathyroidism. So the investigations that need to be done in any patient with hypercalcemia is basically a parathyroid hormone level, a 25 hydroxyvitamin D level, a parathyroid hormone related protein. This is not very easily available, and screening for appropriate malignancies. The clinical manifestations of hypercalcemia depend on the degree of hypercalcemia as well as on the rapidity of development of hypercalcemia. We can find patients presenting with increased fatigue, nervousness, muscular weakness, increased sleepiness or depression. Patients can have GI signs of constipation, nausea, vomiting. Very severely high levels can result in peptic ulcers, pancreatitis. Renal signs are basically of polyuria. Those who have persistent hypercalcemia resulting in increased calcium in the urine being excreted can develop urinary tract stones. They can also develop medullary nephrocalcinosis and chronic tubulointerstitial disease. Neuropsychiatric manifestations of hypercalcemia are common, like headache, loss of memory, somnolence, stupor, and coma. Those with prolonged hypercalcemia can develop calcium deposits, crystal deposits in the conjunctiva and conjunctivitis, as well as band keratopathy. Now, continuing the patient's examination, we find that the imaging of this patient was normal. ECG showed evidence of LVH, and USG abdomen showed cholelithiasis, but no evidence of cholecystitis. The working diagnosis was acute kidney injury, query prerenal, or maybe induced by NSAIDs, because she was taking NSAIDs for osteoarthritis. However, review of prescriptions and medications revealed that she was taking a 60,000 international unit dose of 25 hydroxyvitamin D daily for the last 10 days. She was just prescribed once to be taken, and she was taking it daily for the last 10 days. She had no previous vitamin D levels that were present. So she was just taking it empirically, and she was taking it for 10 days. Now, if we look at vitamin D recommendations, so in adults, the recommendation is to, if someone has levels less than 30, to take or between 1,500 to 2,000 IU per day. This is to be taken till the level is above 30. And in elderly, too, the level required is the same. For someone with very severe deficiency, we can prescribe them 50,000 international units once a week for 8 weeks. And this is to achieve a 25 hydroxyvitamin D level above 30. So 60,000 units being taken daily for 10 days is a really high dose that she was taking. So when we review the literature, we found that there is growing risk of vitamin D toxicity with inappropriate practice. And this has been found more in the Indian subcontinent. Vitamin D being the most popular vitamin these days, which is being used from everything from COVID to atherosclerosis. We found that there are very large number of citations of vitamin D. This is the most investigated vitamin these days. And with around 6 lakh citations over a 16-year period were there. And the diagnostic cutoff for vitamin D intoxication is basically more than 150 if microgram per liter unit is used. This patient had a very high level of 480 microgram per liter. We did not investigate the patient further because we had an appropriate cause for hypercalcemia in vitamin D intoxication. We just managed her with IV normal saline along with supportive measures, and we gave her Lasix injections because this promotes vitamin D excretion from the genetic urinary tract, and she had rapid recovery of renal functions and improvement in her GCS without requirement for any dialysis. Now, in treatment of hypercalcemia, basically the first step would be to expand the volume with isotonic saline because these patients are dehydrated. Once the volume is expanded, we can use loop diuretics like Lasix or furosemide or torsemide. Bisphosphonates are used for cancer-related hypercalcemia. Calcitonin can also be used, but there is rapid tachyphylaxis. Densumumab can be used for those who are bisphosphonate refractory. Steroids can be used in vitamin D intoxication in severe cases, or in case of endogenous origin of vitamin D being produced, like in granulomatous disease, we can give a trial of steroids to bring down the level. And then we can use CASR agonist, that is cinacalcet, which can be used in primary hyperparathyroidism specifically. The next case is of a 23-year-old male. This male presented with generalized anasarca for 1 month. Investigations revealed that his hemoglobin level was 13.2. Urea and creatinine were borderline. Creatinine was slightly elevated, 1.5 milligram per deciliter. Sodium was 132, slightly low. Potassium normal. Calcium level was quite low, 6.4 milligram per deciliter. Phosphorus level was 2.4 milligram per deciliter. Serum protein albumin was 1.6 and globulin was 3.6. So he had significant hypoalbuminemia. And serum cholesterol was 426 milligram per deciliter. Urine showed 3 plus proteins with few plus cells, no RBCs, and he had 24-hour urinary protein excretion of 6.4 gram per day. So this is basically a patient of nephrotic syndrome with hypocalcemia being present and hypoalbuminemia being present as well. So whenever we look at hypocalcemia, the first thing that we need to do is look at the albumin level, because when there is decrease in the albumin level, the total calcium level tends to go down by 0.8 for every gram of albumin that is decreased. True hypocalcemia only occurs when the ionized calcium level is low, and this again can be with low or high phosphate levels. Next, this patient's diagnosis was basically nephrotic syndrome. This patient did not have true hypocalcemia, as the corrected calcium was 8.96 milligram per deciliter if we correct using the fall in albumin level from the normal value of 4. So this patient had normal ionized calcium, no hypocalcemia, just incidentally detected pseudo hypocalcemia. Next case is basically of a 45-year-old male. This male presented with generalized weakness and nausea for 6 months, and on examination there was pallor, blood pressure was high. On investigation, we found that this patient had very low hemoglobin 6.3 and very high urea and creatinine values. Urea was 220, creatinine was 8.4. We asked him if he had any previous reports. He told that he had no previous reports available and he was just presenting recently. We found that this patient had a calcium level which was 6.9 milligram per deciliter. Albumin was 3.2. However, even if we correct for albumin, we found that the calcium level was slightly low, around 7.8. Urine showed 3 plus proteins and RBCs being present in urine. However, ultrasound showed very small kidneys, bilaterally small kidneys with loss of corticomedullary differentiation. Vitamin D level and IPTH are usually done in patients with chronic renal failure when they present, and he had low vitamin D levels and a high parathyroid hormone level. So this patient basically has CKD5 and he has secondary hyperparathyroidism. Let us now look at hypocalcemia that occurs in chronic kidney disease. Whenever there is reduction in the GFR, there is reduction in the production of 125 dihydroxyvitamin D3, that is the activated form of vitamin D. And along with that, there is phosphate retention and hyperphosphatemia, which again increases the FGF23, which again in turn leads to decrease in the vitamin D levels, and this results in hypocalcemia. Whenever there is hypocalcemia, there is secondary hyperparathyroidism that develops, as well as it develops because of diminished calcium sensitive receptors, as well as diminished vitamin D receptors, and skeletal action of vitamin D of parathyroid hormone is resisted, and all these results in secondary hyperparathyroidism. This is in fact a soft marker for chronic kidney disease in patients who do not have any previous reports. If we find hyperparathyroidism, that can be an indicative that this patient is having chronic kidney disease rather than acute kidney injury. So hyperparathyroidism in CKD can develop when the GFR falls just below 60. that is when the patients develop CKD stage 3. There is elevated phosphorus and low calcium when the GFR tends to come down to around 40, and it is usually managed with a low phosphorus diet along with phosphate binders, vitamin D analogs, and calcium mimetics being given if the calcium level is normal. Parathyroidectomy sometimes may be done if medical management fails. Now, this patient, he is initiated on all these therapies and he does quite well. And he is initiated on dialysis as well. And then he presents after 3 years. And he's on maintenance dialysis for 3 years. Native kidney disease, as we saw, he was having proteinuria as well as having RBCs in urine. So his native kidney disease was presumed to be chronic glomerulonephritis. He now presents with worsening BP control, and there is pallor present, bilateral pitting edema. Systemic examination just does not show any abnormality otherwise. Investigations now show that he has hemoglobin level of 9.2, which is okay for our CKD stage 5 patients. Urea was 184 and creatinine was 8.4. He had undergone dialysis 3 days back, so this is not very bad in terms of that. Slight hyperkalemia being present. This is usually present in almost all chronic kidney disease patients on dialysis before they require dialysis, like after 2 days of dialysis or so. Phosphorus level was high, 5.8, not very high though. And calcium was high. For the degree of hypoalbuminemia, 3.2 gram of albumin being present, his calcium level was high, as well as alkaline phosphatase level was high. And PTH level and vitamin D level showed vitamin D being adequate, whereas the parathyroid hormone level was markedly elevated, 3200 this time. So what basically happens is, this is basically renal osteodystrophy that is being seen. These are brown tumors which have developed following hyperparathyroidism being present for a very long period of time. Uh, this is again the parathyroid hormone that the target parathyroid hormone levels. As in dialysis, these patients have some resistance to parathyroid hormone. So our target is no longer a normal PTH level in these patients. We tend to maintain the level between 2 and 9 times of normal. Whereas in other cases like CKD stage 3 and stage 4, we tend to maintain levels between which is normal. Now, hyperparathyroidism with increased calcium and increased phosphorus as well, uh, with the parathyroid hormone level being very raised, is usually found in tertiary hyperparathyroidism. So basically what happens is patients have hyperparathyroidism for very prolonged period of time, and then they gradually develop autonomous nodules which start secreting large amounts of parathyroid hormone, which can be seen on an ultrasound. This patient, again, we did an ultrasound and which revealed a small nodule in the parathyroid gland. We can get a 99 technetium system MEB scan or a MEB scan, which can help in parathyroid localization. This is specially done if an operation is planned so that the operation can be done. So if the patients have parathyroidism, hyperparathyroidism, very severe, and there is evidence of calciphylaxis as well as evidence of osteoporosis, bone fractures, severe bone pains, vascular calcifications, then these patients may undergo parathyroidectomy. But usually a medical management of 6 months is advised before we go on with all this. Now, looking at hypocalcemia, now hypocalcemia can again be divided into two basic groups. One is that associated with high phosphate levels, and that associated with normal or low phosphate levels. So with those with high phosphate levels is basically those which is present in chronic renal failure, as we saw in this particular patient that we had, or it can be due to hypoparathyroidism, which can again be post-operative as well. And post-operative hyperparathyroidism can result in very severe hypocalcemia, very difficult to manage, or it can be acquired hypoparathyroidism due to irradiation or amyloidosis. Then we can have hypocalcemia with normal or low plasma phosphorus levels, which can be due to vitamin D deficiency, either due to decreased intake or decreased absorption, or decreased vitamin D generation, either due to liver disease or anticonvulsants. Again, early renal failure can sometimes result in hypo or normal phosphorus levels and hypocalcemia, or resistance to calcitriol, which occurs in type 2 vitamin D dependent rickets. Acute pancreatitis can result in hypocalcemia as well as magnesium deficiency. And finally, the syndrome we were talking about, hungry bone syndrome, which is basically after post-surgical treatment of hyperparathyroidism for vitamin D deficiency. Clinical manifestations again depend on the degree of hypocalcemia as well as in the rapidity which with it develops. And these patients usually present with fatigue, weakness, increased irritability, loss of memory, confusion, hallucinations, paranoia, depression. Paresthesias, muscle cramp, frank tetany, laryngeal stridor, or seizures can also occur. Two signs that we have very frequently learned about in our MBBS days are the Vostek sign and the Trousseau sign. The Vostek sign is basically if we tap on the facial nerve branches, it can lead to twitching of the facial muscles. This basically shows hyperexcitability. And Trousseau sign is basically carpal spasm, which occurs by inflation of the BP cuff. Cataracts, brittle nails, and absent axillary or pubic hair too might be present. Now, on the ECG, we can have increased QT interval as well as arrhythmias being present. And plasma PTH levels can be increased in CKD and pseudo hypoparathyroidism, whereas it is decreased in hypoparathyroidism and magnesium deficiency. Treatment of significant hypocalcemia is basically IV calcium gluconate bolus, and this is followed by 12 to 24 grams of calcium being given over the next 24 hours IV in dextrose water. And active forms of vitamin D like calcitriol or alpha calcidol can be given. Thiazide diuretics can be given for those with prolonged hypocalcemia. Basically, it decreases the excretion of calcium in the kidneys by the kidneys. However, hungry bone syndrome can still be very difficult to treat, and they usually require management in a hospital setup. So with that, I come to the end of my presentation of hypo and hypercalcemia. And we talked about three cases and the basic causes of hypocalcemia, the basic causes of hypercalcemia, and how to go about the management of the same. Thank you.